it should be very less. If it's 3, then it's moderate. If it's 4 or 5, then it's high risk. Now, if you have 2 moderate or 1 high risk, then it's a strict no-no for refractive surgery. If it's 1 moderate risk, then you need to look at these patients and monitor them. Then you come to the BELIN AMBROSIO display, which has multiple D values like anterior elevation, posterior elevation, pachymetric progression, thinnest point of the cornea, and displacement of the thinnest point. Now, basically, these are color
Sorry to interrupt, ma'am. You have to please sum it up in next 30 seconds. Your time is up.
Yes. So these are various gates that you have. So you have a color coding of yellow at 1.6 and red at 2.6. You have the EKR graphs that you can see here. You have the tomographic and the corneal biomechanical index. You have the angle kappa, if it is abnormal. Then a lot of other maps like the refractive true net power map, EKR map, TCRP maps. So to conclude, all the postgraduates need to know about these maps so that you have a good hold on and read these maps very well. Thank you so much for your kind attention. Thank you.
Thank you so much, Dr. Naga, for the wonderful presentation you have made. It will be very helpful for the postgraduates, and especially in coming days, refraction and pentacam and this topography will be one of the most important things in times to come. Since we have lost time for discussion, we'll try to make up and we'll go ahead and straight invite our next speaker for today, Dr. Chandrima Paul. Dr. Chandrima Paul is the Director for Glaucoma Services at BBI Foundation in Kolkata. She has made several presentations at the American Academy and the ESCRS. She is the recipient of Dr. D.B. Chandra Award and Dr. B.K. Mitra Award. She has done her PhD also from RIO, and she will be talking to us on reading a visual field report. A very warm welcome to you, Dr. Chandrima Paul.
Thank you very much, Dr. Satyajit, for those kind words. Thank you, ARC team of the AIOS and the chair, Dr. Chitra. So, dear postgraduate trainees, I'm going to take you through perimetry. I'll go through only the salient features in the interest of time. So this is a Humphrey single field printout. As you can see, I'm concentrating on the Humphrey because that's the more commonly used perimeter. So the red box there, zone 1, actually gives you the data and you know what how the test conditions were when the test was started. Zone 2 actually gives you the reliability indices and you know the fixation losses and the test reliability. Those are the numericals. The figures in brackets are actually the standard fluctuation, and here you need to look for any abnormal high fluctuation like say 40 or so on the edge, which is not physiological. This is the mean deviation, which actually is not only related to glaucoma, but could be an underlying retinal cause or any other pathology. And this is actually what we as glaucoma people look for, the pattern standard deviation. And the gray scale is basically not of much importance. Those are the global indices that you see. And this is the glaucoma hemifield test where the two mirror images of the two hemispheres are compared and you get several images like outside normal limits or within normal limits or borderline. So just to start with a few pitfalls which you need to know to recognize a standard field. So here you see up-to-date refractive, you have to up-to-date your refractive data or you'd get a refractive scotoma like this. So the correct trial lenses should be put, the spherical correction closest to the patient's eye and cylindrical lenses to be oriented after that in the angle of astigmatism. Thus the Clover defect, which is characteristic of a fatigue field with high false negatives. That's a white scotoma, the white areas, so-called white scotomas in the grayscale that you see and not in the periphery are actually high false positive results. And that's a low-hanging blind spot where the blind spot, as you see, is further down. And that is actually because of the patient's head being tilted during the test. And this physiological blind spot is represented as a scotoma in the lower temporal field. This is when you're using trial lenses far away from the eye and you get a typical rim bar artifact like this. And you could get something like this where the PSD is 2.87, but actually the pattern standard has nothing at all. That could be a pseudophakic PCO, and a macular grid laser done underneath could actually give you a bi-arcuate, false bi-arcuate. Advanced field loss could be given like this, where you see the pattern standard absolutely is clear. So these are points which you should look for when you're actually looking at the field. These are a few points which I've put together, and you can look it onto the net, so I won't go through in detail. Like the operator has to be very, very updated, and whenever in doubt, please consult your technician of the Humphrey as to what actually happened. So a few words on progression. This is the Humphrey progression that we see. So the open triangle is the first time progression that you see out there. The half black triangles that you see are detected again on the next examination. And the completely black triangles that you see are actually the confirmed on third test. So in progression, we basically follow an event analysis and a trend analysis. So taking both into consideration, we get this kind of a message like, say, likely progression. And this is actually according to the criteria of the early manifest glaucoma trial. So here I have to bring in the octopus, because the octopus actually is way forward of the Humphrey in detecting projection. So here you see this is the mean deviation. That's the local values that it gives. That's the defect curves. And here you have the local with the defect, with the area, focal area. So here, as you see, it's quite clearly given where the red triangles are, and these are the lines which show you the progression compared to the optic disc that you have out there. So if you have a look at this, this is the line where the sensitivity loss started, the blue one, and the yellow one is where it ended. So that's the line actually which shows the progression, and here it is marked in red in one of them. So in the interest of time, I'll move on to some examples. Like you see out there, this is a field where I've told you about all these. Once you're satisfied with all these, then you come to the pattern deviation, where you see points out here. The Anderson's criteria is fulfilled, and that's a nasal step that you see. So that is definitely an abnormal field. If you look at this again, after looking at the rest of it, that's a early arcuate defect which is developing. And this, if you see, is around the paracentral area. That is one of the earliest defects that we see in glaucoma, forming into a paracentral scotoma. So this is a very classical arcuate defect, the superior arcuate defect, which we see. And once you're satisfied with all these things, this is a field which is quite satisfactory in all aspects. So this could definitely be labeled as the left eye with a superior arcuate defect. Let's have a look at this. This is again, as you see, a paracentral going into an arcuate and a very early arcuate starting out there. So this could be defined as a early inferior arcuate defect with a superior arcuate defect. So this is of both the eyes. So here, the left eye and the right eye to your right. So this is actually almost resembling a biarcuate defect that you see out there. And here we have a dense superior arcuate with a inferior arcuate just forming. This is a field again where which is of advanced glaucoma, and we'll move on to the next ones which I want you to see. So this is a typical field of a very severe glaucoma patient, where you, in the right eye, the disease is not so well progressed. So you see an early biarcuate forming, but in the left eye, we could not do a 24-2, we had to do a 10-2. But by no means should you compare a 24-2 with a 10-2, they should be treated separately. But when you really cannot get a 24-2, you have to move on to a 10-2. These are actually neurological fields, and I thought you need to know to distinguish them from the glaucomatous fields. So here we have the bitemporal hemianopia with not respecting the central meridian. And here we have, which is respecting the central meridian. That's also another neurological field, but always remember, when you do neurological fields, it's always better to do them 60-4 and then also a 10-2 to know exactly where you are. These were actually treated as glaucoma patients, so they were that's the best field to do for a glaucoma patient, where the patient can cooperate well with the test. So a 24-2 was done. And that's when you get a general reduction of sensitivity. So when you get a field like this, you actually really, in all cases, actually, you should not treat the field in isolation. You have to look at the clinical parameters and see what the other parameters are, and then treat the patient. And then just we'll run through each of them. That's the nasal step, the paracentral defect, as I told you, the temporal wedge that you might see. Altitudinal, you must distinguish it from the arcuate, because altitudinal is generally from ischemic reasons that it happens. And that's an advanced field defect, which I told you. So thank you very much for your attention.